Oh man, this is a fantastic day for us. So I don't know if you guys remember, we were a couple of weeks ago. We did Men's Health weekend show. Today we're talking about the ladies, Women's Health Saturday, and I have two of my most favorite people that are providing health care to women and doing a really important job. And so we're going to talk about some very important women's health issues with Bethany Kolb, who is an OBGYN with Presbyterian, and she specializes in perimenopausal health as well as delivering babies still, which is just a great combination. We were joking that our two careers are the same. One day we'll help bring a kid into this world, and the next day we're dealing with things like menopause. And so it's a very varied career. And we also have Katie Sanchez, who is with New Mexico Cancer Center, cutting edge stuff on treating mostly breast cancer. I think that's the focus of your career. So let's start with Katie, because my most hated disease in neurosurgery is, and we were just kind of talking about this, is when breast cancer makes its way into the brain or the spine, and I had to take that out, and sometimes it's just an awful scenario. A 33-year-old woman who has two kids, for example, this was a recent case of mine, and just showed up with headaches, and the next thing you know, we found a bunch of brain tumors from breast cancer, and that's how it was diagnosed. She didn't know she had it. What is happening now? Are people living longer? Are they surviving? Is breast cancer not as horrible as I think it is?
Well, thankfully, breast cancer is changing. We 7-10 years ago, we would talk about life expectancies for people who had stage 4 cancer or advanced cancer that can't be cured as maybe being a couple of years.
Right.
And we had the exceptions, but the average has shifted. And most people, even with pretty aggressive cancer, are living at least 5 to 7 years. And we've had a couple really big changes that have shifted things by a year or two in terms of overall survival. And our treatments are just changing rapidly. So I think the breast cancer, thank goodness it is changing. Also, most people have curable disease and most people are cured from breast cancer.
Yeah, that is so remarkably different from when I was a wee pup of a doctor. I mean, it was always depressing. It was always tough to tell the family and the patients. Can you give us a sense of what the statistics are? You know, how many people will get it? What the prevalence is sort of in the community?
Breast cancer in general affects 1 in 8 women
Okay.
and 1 in 800 men.
Oh, really?
Mm-hmm. So 1 in 8 women is pretty common, 12% population, which is why we do mammograms. And, we used to start mammograms at 50, and that has shifted maybe about 10 years ago to 40.
Wow.
And, we used to say, oh, they stop at 70, and now women are living until their 90s.
Right.
And we see breast cancers in their 90s. So we say they should continue probably until you have a life expectancy of around 10 years.
Okay.
And, it is just changing. We are seeing younger cancers, but I think we're diagnosing them earlier. And then we're also screening women who are at high risk. Yesterday I saw somebody who was pretty young and was screened and had a cancer that was smaller than the tip of a pen.
Right.
And a couple of years ago, the technology didn't exist that we could have even found that cancer.
Yeah, that's remarkable. Can you go back to the whole men having breast cancer thing? I know this is Women's Health Saturday, but so I have a strange, little anecdote, which is that sometimes we diagnose pituitary tumors with men that come in and they have milk leaking from the. So breast tissue in men is a real thing. It's not as though we don't have it. Just give me some idea. So it's 1 in 800, and how do they diagnose it? Somebody comes in with a lump, or how's it happen?
Yeah, usually their wives find it. Or, the other thing is sometimes they're using a lot of testosterone.
Okay.
So really high doses of testosterone replacement can sometimes be a trigger. Some men have more breast tissue. They tend to be men who are heavier.
Got it.
But it's still, not particularly common, but it's not unheard of. So it is something that, we all should do a check. And it's important for both men and women to be aware of changes in their body.
Hey, Aaron, it sounds like you and I got to start working out.
I'm not checking you.
I need you to just feel this lump. Oh no, that's the
And-
nipple. All right.
Some families can have a genetic propensity for having male breast cancer, correct?
Yeah. Cancer in general, there are some familial syndromes or, cancers that can run in families. Their most common are, some genetic changes that we're familiar with.
People talk about the BRCA gene. Do you want to just take a minute, and then we're going to switch to Bethany?
Yeah, the BRCA gene is a breast cancer gene. And it's actually no longer just BRCA1 and 2. There's around 8 genes that are associated with breast cancer. And all of them are slightly different. But they are, syndromes that run in families. And so usually you'll hear, that like my aunts, my uncles have prostate cancer, my aunts have breast cancer. And so it's usually a prostate breast cancer. Sometimes there's pancreatic cancer in those families as well. And some people need additional screening. So usually if you can tell a cancer family in your story, I always think you should talk to your primary care about, do I need to be screened differently than the average population?
So just one more point. So if somebody says, I have a positive BRCA gene, that means they're at higher risk.
Yeah, so BRCA1 is one of the 2 mutations. The breast cancer risk is around 80%.
Oh, wow.
in a lifetime. BRCA2 is around 60, 60 to 80. So that's why we discuss having prophylactic mastectomies in that case, because
when you're young, right?
Yeah, as soon as you're kind of done having children or ready, and that's because your risk, a lifetime risk of 80%, is pretty significant, and most people, it's just exhausting to do all the screening every year.
Angelina Jolie did that years ago.
Mhm.
That's right.
She
had a family history.
Yeah, she had a family history, and I think they found that gene inside of her, and she just decided to, I'm going to do this, and did it.
So anecdote again, my mom had that done, and she was probably in her late 40s, I think. So it was a long time. It was back in the 80s, but so in terms of women physicians, I have great respect for women physicians. My mother was one of the first in the country. In 1957, she became a doctor, and there were, I think, 3 women in her med school class. So it was pretty rare. She had a very interesting career. She ended up, she was a sort of a forensic psychiatrist and ran a state hospital. So she dealt with the schizophrenics and the murderers and everything like that. And dressed to the nines, would walk through, and people are like throwing their poop on the walls. And my crazy brothers grew up. They had, back then, the state hospitals were very elegant. The doctors had a lounge and tablecloth, and it was a very big deal. And so my brothers remember that, and of course it all went away. But anyway, so Bethany Kolb is...
Hold on. Before we get to Bethany, let's take a break. We need to take a break, and then we'll come back and we can get to Bethany.
I just don't want her to feel like we're ignoring her.
We're not. She's going to get the whole next segment. Yeah.
All right. Hang tight. We're going to come back in a minute. Fisher, neurosurgeon. I'm talking to two of the most important lady physicians in all of Albuquerque. Bethany Kolb is a specialist that deals with perimenopausal issues in women and also is a practicing obstetrician. The question that it's sort of come up in my practice and that I wanted to start out with is, when does menopause really happen? So a lot of my wife even is complaining that, she's listless and she just turned 40 and she's 39. 40, and she wants to know what the signs and symptoms are, and is that the appropriate age to talk about it? Does it come on earlier or later? Is it an age thing?
It is. And, I think that's a great question, because one of my passions is really that we as physicians, and particularly primary care physicians, should be doing more anticipatory guidance, right? In my perfect world, her doctor would have already brought this up and started talking about this transition with her.
I think I'm her doctor.
Uh-oh. Well, we'll inform you, and then in case she doesn't
thank you.
in case she doesn't listen to your show.
I know a couple of the systems in the body, but okay, go ahead.
The way I think about it really is that, menopause is the transition getting you out of your reproductive years as a woman. Puberty is the transition that gets you in. Menopause is the transition that gets you out. Or, as somebody on the internet said recently, cougar puberty.
So generally it's sort of a loss of estrogen and a rise of progesterone. Is that somewhat correct or not?
Well, the way I think about it is women are born with all the eggs we're ever going to have in our ovaries. And over time, we use them up by ovulating and they die off as sort of a natural process. So perimenopause is that process of the ovaries kind of quiet quitting. Some months they're doing their thing. They're like, yes, I have an egg. I'm going to ovulate. We're going to do the thing we usually do. And other months they're like, I didn't find an egg. I'm not going to do my thing. And the result is wild fluctuations in particularly estrogen. So instead of the sort of normal up and down of the reproductive years, you get this wild fluctuation. And so a lot of women feel that very symptomatically, because there's estrogen receptors really all over our bodies, the brain, everywhere. And, some women particularly who have trouble with premenstrual syndrome, that becomes very dramatic for them, because it's like constantly randomly going in and out of PMS. Women who experience, this is a big crossover with you, migraines. So a lot of women experience hormone-related migraines. So this becomes a really difficult period for them. Typically, we see women, sort of moving into this phase, sometime mid-40s, but certainly I have plenty of patients in my practice who are early 40s or even late 30s and starting to experience some symptoms.
So two questions come to mind.
Yeah.
Is everybody's experience the same? I mean, you call up your doctor, you're like, well, I got the X factor. I'm not having periods anymore.
Mm-hmm.
Is there some measure by which people will know they're in perimenopause, for example? Because it seems to me it's confusing. There's a lot of different things. There's flashes.
Confusing.
There's being totally unreasonable at 40, honey. Just kidding. No, but I mean, is there anything that a red flag kind of thing? I guess my first question.
Certainly hallmark symptoms that most people are aware of relative to menopause are what we call the vasomotor symptoms, the hot flashes, the night sweats. And a lot of women get those, but not everybody. I think other very common symptoms are sleep disturbances.
Oh, really?
Some of the mood disturbances are very tough on the perimenopausal women in particular. We actually have some data on that. So, women who either have struggled with mental health issues previously, having, sort of a worsening, or people who have never experienced any mental health issues, suddenly experiencing anxiety or depression. Those are some things that, women don't really correlate with possibly being a perimenopausal, issue for them. So they don't get addressed.
That makes sense. And I guess my second question is, how long is, I get this question a lot, like, how long is this going to go on for? Because apparently it's pretty unpleasant.
Yeah.
Men have like a bad day and then we're mad about it. We punch a wall or something and then we're okay. Is this many years? Do some women go through it in 6 months? I mean, like, what does it look like?
It can be. The average is sort of 5 to 10 years around that menopausal transition. So, sort of counting from when in perimenopause a woman starts to have symptoms until she tends to have a decline in symptoms. And, some of the symptoms, if you looked at a graph, are sort of more loaded in the perimenopausal phase.
Okay.
And, postmenopause being when you have a year without having had a menstrual cycle. And then that postmenopausal phase, tends to have, predominance of other types of symptoms. But hot flashes and night sweats tend to decrease over time. Some things like sleep disturbances are also associated with age. So, there's some things that are associated with menopause, transition, some things are associated with age. So it sort of gets a little even more confusing.
What's the latest you've seen somebody go through menopause? Can it happen in your 60s, for example? Or?
That would be pretty late. I mean, it's a curve, so there's always some people way out at the end of the curve. The average age in this country of, being postmenopausal is about 51.
Okay.
So I consider somebody to be late, when they're 55, 56, I've had somebody 58.
Okay.
But that's getting, fairly late, where we start to worry because postmenopausal bleeding is abnormal
Right.
and can be an indication of uterine cancer. So, then we always get a little bit concerned if somebody's still having bleeding, later.
So let me throw it open as a question to both of you then. So is cancer in women related to estrogen levels? And is that group of women more at risk of things like breast cancer or other cancers? Do you get to a certain point in your life and all these fluctuations and or hormone replacement therapies, do those expose this group of women to higher risk of cancer?
So that's a complicated question. A lot of, in the menopause world, we get a lot of our information from the Women's Health Initiative, which was a study from the late 90s that was stopped because they saw not quite statistically significant increase in breast cancer for women who had to take estrogen and progesterone, so women with a uterus. So that was the group that saw a slight increased risk in breast cancer. We can get into the numbers if you want. But the women in that study who only were on estrogen had actually a lower risk of breast cancer.
Oh, wow.
So, that shows you what a complicated question this is about, breast cancer and exposures to estrogen. And I'll let Dr. Sanchez chime in on her experience.
Should women be using the hormone replacement? Is it okay again? Or I'm so confused.
Yeah, we can. So generally cancer risk increases as you get older.
Okay.
So, the cancers we see, everybody see those 30-year-olds on the news or the 40-year-olds. We see them and they stick out in our minds. But the average person we see is usually in their mid-60s.
Okay.
But breast cancer risk does increase as we get older. So we do see a lot of breast cancers that are around the age of perimenopause. And part of that is probably because it's the first mammogram someone's ever gotten.
Okay.
So I don't know how much of it is sometimes it's like, we're no longer talking about fertility. And so we're talking about what else we can do. And so cancer screening, primary cares are reminding people to get mammograms the older they get. So I think that's probably why we see so many kind of perimenopausal, breast cancers diagnosed at the age of 50. Hormone replacement therapy is a very complex discussion, even for physicians. And hormone replacement therapy makes people feel better. And, there's the symptoms that people experience are real. But I think if you just follow social media talking about what happens when someone goes through perimenopause and menopause, as a woman, I'm thinking to myself, like, my gosh, I'm going to be demented, falling apart, have no sex life. It's really terrifying. Your bones are just going to start crumbling.
Right.
That's terrifying if you listen to social media about this, that, you can identify all those symptoms. And it's really hard because I think women have a lot of chronic stress, and it's a really stressful part of someone's life when they have kids are getting older and full-time jobs and, all the other things. So I think that it is complicated, and it's a decision that should be made carefully if someone considers it. And you probably make those decisions a lot more frequently than I do. We can see, breast cancers after hormone replacement therapy. They don't generally cause them, but they can feed them.
Got it. We're going to take a break. This is an amazing discussion. I think anybody who wants to call in and talk about their experience, if they've either had breast cancer in the family or have it themselves and want to share, we are happy to take on those questions. Jerry, we got a break coming up.
You want to give them the phone number?
Oh, yeah. So call in at 505-243-3333, KKOB, and Dr. Scher, the doctor, is in, and we would love to answer anything you got. All right, we're back on Dr. Scher, and I'm interviewing Bethany Kolb and Katie Sanchez, two of our leading women physicians in Albuquerque. By the way, before Aaron's here also.
Yeah, you have to. I'm not doing this for recognition, but we also have to recognize Katie because she is this year's Albuquerque the Magazine's top doc for oncology.
Unbelievable. Bethany, you want to? Katie, you want to start first? How can someone get an appointment with you if they need it?
Well, hopefully people
don't need
me. Yeah.
Occasionally people.
I was joking around. My husband's a criminal defense lawyer and mostly does felonies, and I do breast cancer, mostly or cancer therapy. And so I thought it's always the worst day of someone's life. But I think if somebody really feels like they have a breast problem, probably is a best place to start with their OB or with their primary care doctor. Usually they see me after a breast cancer diagnosis. That being said, in New Mexico, for people who don't have insurance, we have an incredible breast cancer screening program.
Oh, cool.
And cervical cancer screening program. And so if you feel like you have a lump and you can't get into a primary care, you don't have a primary care, can't get into an urgent care, don't have insurance, they will get a mammogram, get you screened, and get you coverage temporarily to have that covered until we've decided if this is a cancer or not. And it's a unique opportunity in New Mexico, and it makes a huge difference.
And that would be at the New Mexico Cancer Center, wherever they look that up.
That's actually a state program. If someone wanted to come and see me, they would usually just ask, call the office and
or
ask to see me.
Primary care and have referral.
Have a referral.
There are people who want second opinions, right? I mean,
yeah, I see a lot of second opinions. I think that, I think people are educated about their cancers this year. I mean, this year, all the time now is more and more.
Right.
And it's a bit of a change. I think people advocate for themselves and they
Right.
are online looking at things, and they absolutely seek second opinions all the time.
And then, Bethany, how could they get a hold of Dr. Kolb?
I work for the Presbyterian system, so, available. My clinic is 505-823-8787.
There you go.
There is a little bit of a wait to see me. There are several other people within the system who are part of the menopause care team. So certainly,
We only bring the high flying, docs on this show.
I did start the menopause subset of our women's health. So really felt it was important and kicked that off in
I just had a
2021.
complaint because there is a way in my chart. You go through the web and you book your own appointment. And this guy was really upset because my first available, if you go through that, was March of 2026. It's not true, but essentially, I guess there's a pool you have to go into before it gets all filtered out. So you can see me earlier than that. All right, so we were kind of going over hormone replacement therapy. Did we finish that discussion? What's the closing thoughts on that question? Should you take it? Is there? I know there's a vaginal cream sometimes that makes people's lives a lot better even if they're in menopause.
So there's, I think, two ways to think about hormone therapy. One is, what we would call systemic hormone therapy, designed to treat those hot flashes and night sweats. It's going to change the level of hormones in your blood. And what we know from that Women's Health Initiative study and the follow-up is that the best time where the benefits really outweigh the risks for women is around their menopausal transition. So even in late perimenopause or after menopause, within 10 years of that final period before the age of 60, is really when we see a little bit of benefit in reducing or not reducing. The way I think about it is keeping you in the slow lane of cardiovascular risk. I tell my patients, we're all on the superhighway to dying of a heart attack or a stroke, right?
Yep.
And, if we die of cancer, well, then we took an exit. Women premenopausally are in the slow lane. We have less cardiovascular risk than our male counterparts. Postmenopausally, we speed up. We move out into the flow of traffic with the guys. And if you start hormone therapy, you get to stay in a little bit slower lane. I can never move somebody back. I can only sort of keep them, where they might have been. And similar for bone loss. Hormone therapy is never going to replace bone density. It's going to help prevent you from losing bone density. So those are some really, things we think about when we're thinking about hormone therapy for, perimenopausal and early postmenopausal women. And then we talk about things like, is there an increased risk of breast cancer in that particular patient?
Yeah, that's the scary question. I guess we don't really know, right?
But even for the Women's Health Initiative, which was more synthetic hormones, we use more body identical hormones now. The risk was similar to if you drink more than one alcoholic drink a day, if you are overweight, if you have an unhealthy diet. So I talk to patients, your breast cancer risk is like a stack of pebbles. We might be putting another small pebble on your risks, but you could also decrease your alcohol intake and take a pebble away. There's a lot of pros and cons.
I'm not giving up my bourbon. I'm sorry. I know I probably should. So Aaron has.
I have a question. So when you're talking about hormone therapies, is it primarily estrogen? And what about women who take testosterone?
Good question. So women who still have their uterus, if we give them estrogen, they need progesterone. Estrogen stimulates the lining of the uterus, so we have to balance that out with progesterone. If they've had a hysterectomy, they can take estrogen alone. And as I mentioned before, that's the group that in the big study actually had lower risk of breast cancer. Testosterone, as far as, guidelines, international guidelines are, the only research has only found that is helpful for women if they have decreased libido or decreased sexual desire. Certainly some women feel like, testosterone is helpful for them in, some other areas. One thing sometimes patients will say if you start them on testosterone is, I feel like I'm living in color again, which I think is a really interesting thing to say. It's a very specific, and more than one woman has said that to me.
Right.
So, certainly the official indication is decreased libido. And unfortunately, there's no FDA approved testosterone product for women. So that gets a little tricky. But, I've found ways to do it. And, certainly some women find it helpful.
Okay. Thank you.
Since we're on the topic, and we prefaced this a little bit before the show, but, people are talking about having sex after breast cancer or perimenopausal, and it's not taboo to think about women's health as a sexual issue. Can you have sex after you've had chemotherapy or breast reduction or mastectomies, or like, what is your practice like? What do you tell women?
Oh, I tell women they're normal.
Cool.
I think even during chemotherapy, pretty limited restrictions and in terms of having sex. And I think that there's ways that, there are some limitations, but I think it can be done safely. I think that people want healthy marriages and healthy relationships after they go through something like that. And for women, I think their sex drive is oftentimes really involved in their, it's very mental for women. And so oftentimes when we talk about how do we get somebody back to a place of feeling like they're comfortable with that part of their lives again,
or attractive, I'm sure that's
all
a
of it.
question.
Yeah. That we really work on the mental piece as well as the physical. So, I mean, there's all kinds of things. There's pelvic floor physical therapy that women go to if they're having pain with sex.
Right.
I think that there are a lot of really good resources about how do you reframe things and become more comfortable in your skin. And then I think people have to be intentional that everything changes as we get older, and that's not something that men and women both go through that.
Right.
And so I think that there are open conversations you can have with your doctor about it, both your OB or a cancer doctor. And I think that most female physicians, I think, are pretty comfortable having those conversations regularly.
I end up, people, I do back surgery on them. And so they want to know. So I get very specific. I say, you have to be on the bottom. And I don't want the stress happening. And I think in this day and age, people are ready for that practical discussion. And those are women. They ask me these things, and I'm sort of delighted by it because I get to sort of treat the whole beast and talk about all the things that were taboo not long ago. I would say 15, 20 years ago, we weren't talking about erectile dysfunction. We weren't talking about women's libidos. Would you agree with that? It's become more permissive for the doctor, at least.
Yeah. And I think when you talk about it more openly, you'll realize that women are worried about their sexual dysfunction, but their partner's sitting right next to them and they also have sexual dysfunction.
Right.
And so when they both are having that, then it really becomes something that's a bigger barrier. And if you talk about it openly, I think that at least most people, it is a part of their relationship. And it is really not an age cap. Sometimes I'm surprised it's people in their 70s who really want to have the conversation, or they really have a symptom that they're having and that they need that to be dealt with before we can deal with anything else.
I agree. All right, Jerry, are we on to a quick break here? And when we come back, we're going to talk about one of our text-ins. It's a question about skin cancer, and it's sort of related to, I guess, all of our specialties. So we'll kind of go over some signs and symptoms of what skin cancer looks like. Take us to a break, Jerry. everyone. Greg Schur is your host, and we're talking with Bethany Kolb, perimenopausal specialist, and Katie Sanchez, who deals with breast cancer. A texter, is that what we call them these days? Someone who texts?
Yeah, so a question on the text line at 505-243-3333.
So this texter is interested, didn't want to come in and talk about the signs and symptoms of skin cancer. He's worried he may have a lesion. Just turns out, I don't know if you're willing to share, Dr. Kolb had a scare with this. And what did you see? Did you see a lesion on your skin?
Well, my very nearsighted husband sleeps on my left side, and he noticed something on the outside of my arm that was actually very small. But, it's really the things, how does it look? How do the borders look? What's the color?
Is it raised? I think
is it raised?
Thing, yeah.
This was a really dark pigmented lesion. That
was it a
noticed.
round mole kind of looking thing?
It was like a Sharpie dot. It was pretty.
really?
It was pretty small.
Dark brown, blackish.
Yep, a little irregular on the borders, and he can see things really well, super close
So
up. And so he said I should get that checked out, and it turned out to be a pre-melanoma.
That's
so,
crazy. What did you know for sure that it hadn't been there before, or had you always had a spot?
I mean, it was the outside of my biceps, so I, it's
which
not
are
something-
enormous, by the way.
Thank you. I work out, which is really important for postmenopausal.
Oh, there we
women.
go.
So not a place I even would have noticed. So
Wow.
important to have your loved ones and keep an eye on places you can't see.
Dr. Sanchez was in the break telling us that there's actually a new way that even a general practitioner can diagnose it in the office. So how's that work?
Well, I think all of us have a fear of missing something, right? Because I am by no means a dermatologist, but I am a cancer doctor. So people see me for their everything else, and they say, "Oh, can you look at my 7 spots?" And I'm like, I should not be the person who's weighing in about this, because I really am afraid that I'm going to miss something that's serious. And there are so many things that are normal on your skin, which I think is the hardest part, is that when you see something that changes, we all have hundreds of freckles and little moles all over our body. And so I think the important thing I always say is that, where I tell patients, take a picture, look at it in a few months, and see if it looks the same.
Yeah.
And in the meantime, you'll be waiting for your dermatology appointment. But I do think
Which
that
is forever in
the
this
future. Yeah. But I think primary cares can also do, most primary care offices have a way to get a biopsy in clinic of something if they need to, or to get into a clinic for a quick biopsy if there's something they're really worried about. I think you can also send pictures in, which is helpful.
Yeah, we send wound pictures, just cell phone shots, and I can decide if somebody needs to be seen if there's an infection. Yeah.
Yeah, and there are some cool tools that are coming out, and I think we all need help, and AI is going to be a part of our lives in ways we can't even expect at this point. But there are some cool diagnosis tools that you can basically scan the blood vessels in clinic. And
With
they
like a little
can,
camera
with
or
like
something?
a little camera attached to your phone, and it can predict what they think it's going to be.
Crazy.
Yeah, that's so. Before, we have another question we have to get to, but you made this great transition. So I always ask all of my guests, is AI going to take your job away? Are you worried about robots? I know a couple of radiologists who are very worried that the algorithms and the AI is going to replace them.
I don't think so. I mean, I think breast cancer is increasingly complex, and I think it's going to be a struggle for oncologists to manage anything other than breast cancer.
Oh, really?
It's just becoming so specialized. And blood cancers are the same. There are some cancers that are very similar, but they tend to be more, there's a couple cancers that are more complex, mostly because we have so much research and so many changes. So I think that my job will not become obsolete, but I hope that some of the mundane stuff that we do in our day does get replaced. I am so tired of, typing and,
Writing notes.
medical necessity letters,
Yeah.
the things that just, make your day feel 3 or 4 hours longer than it should. And I hope that AI can help us with those things. If we fight it, it's going to feel uncomfortable, but I think if we embrace it, it's just going to become a part of our lives.
If I could get the computer to respond to the peer review questions about how many levels of spine surgery I think I really need to do in this case, it's so annoying. Then I would do that. Is there a future for AI or robotics in what you do, Bethany?
I agree with Dr. Sanchez. There's a certain aspect of our jobs that I think is hard to replace, but it would be nice to see technology help us with some other sticking points. I joke with patients that I need a hologram of myself doing the education piece, because that's an exhausting part of my day, that I say the same thing over and over again. And I'd love to send the hologram in ahead of me, do some of the education and explaining, and then I can come in and do the more subtle things, because there's a lot of counseling in my appointments.
So you don't think robots are going to be delivering babies tomorrow?
Probably not.
Okay.
The Terminator came out before Multiplicity did Multiplicity. So Skynet is real, AI is taking over, and then we're going to be able to clone ourselves and have them do things for us in the future.
So these people knew what we were saying. So I want to get back to an important question that had come up, and there is a lot of confusion about in menopause and perimenopause symptoms. If hormone replacement therapy is scary or concerning, or we're not sure about it, can you use creams, estrogen creams, for example, to rejuvenate and feel better? Is that still feasible?
Outstanding question. So there is a piece of the menopause transition that it got a really long name recently, called genital urinary syndrome of menopause, which used to be called the very sort of unpleasant name, vaginal atrophy. This is really linked to dryness. The vagina likes estrogen, and patients, as their estrogen decreases around their body, they tend to feel just a general discomfort, and a cranky bladder, pain with intercourse, loss of elasticity, loss of lubrication. And like Dr. Sanchez was saying, this really ties into sexuality for women. And unfortunately, a lot of women just feel like this is part of growing older. And I tell people this is common but not normal. Another thing is it's really linked to an increase in urinary tract infections for women as they go older, recurrent urinary tract infections. And for women who are quite a bit older, this can be really significant. Women die of what we call urosepsis, an advanced urinary tract infection.
And it gets into the brain and spine in my world.
There's a lot of, potential problems around, recurrent infections. So in my world, I think every, woman who's postmenopausal should be offered vaginal estrogen. And Dr. Sanchez and I were talking before the show, it is really safe for everyone, even breast cancer patients, because it doesn't really affect your circulating estrogen. I tell patients
it doesn't really get in the bloodstream.
It doesn't really get into the bloodstream. I tell patients it's skincare for down there. I want you to take your vaginal estrogen cream. I want you to rub it in. It shouldn't be
Aaron,
messy.
You can't use it, Aaron.
It shouldn't be messy. It's safe. It's not, well absorbed into your bloodstream as the user. So it's not significantly absorbed into your partner's bloodstream. That's a question I get. Can I have sex after I use my vaginal estrogen? So, if I could have everybody take away one thing, it's that vaginal estrogen is safe and also can be life-saving.
So I have to go a little controversial on you both. I was in the clinic the other day, and this patient came in. It was a middle-aged man, and he had significant problems with osteoporosis, which is a little bit rare for a 50-something-year-old man. And we got to talking, and good sense of humor. We had a good back and forth, and he says, well, I'm just worried it might have something to do with my uterus. And you can imagine my confusion. So it turns out it was a woman who transitioned to be a man, and I would have never known. A full beard, looks perhaps even more manly than I do. Are you guys dealing increasingly with transgendered patients that have hormonal issues? And secondly, what if that man is going through menopause and you have to guide them through it? Is this something you see?
It is not something I've seen a lot of. I think it is an important issue. And if it is presented to me, I'm going to have to do a deeper dive on how to handle it, because I think it is complex. I've dealt with it on the obstetric side of my job.
Oh, sure.
Which is also another interesting challenge. But it is something to think about, and particularly for trans men, because they are suppressing, estrogen, osteoporosis does become a big issue. And, in general, postmenopausally, women have a lot of fear around breast cancer,
Right.
and sometimes not as much appreciation for the impact of osteoporosis, because the osteoporotic fractures and the sort of impact on your quality of life and your lifespan is similar to breast cancer. You know, and
Interesting, right.
the death, the number of deaths and the reduction in your years of life. And, I see women all the time who are sort of scared of the treatments for osteoporosis when, your risk of a side effect from your osteoporosis treatment is tiny, and your risk of a bad outcome from your osteoporosis is almost 100%.
I am putting a lot of cement in people, and of course they're living longer and want to be active, and so
Yeah.
the osteoporotic fractures, you're right, it's a tremendous problem. People are getting, there's so much more of it nowadays. So have you, Katie, I'm just wondering if you dealt with that breast cancer in a man that's transitioned?
Yeah, trans
Yeah.
women. Are you seeing? Is there a higher instance of?
I rarely see it. I have a couple, but I think that's because I'm a specialist and people, reach out when there's something that's so rare. I mean, we just, I don't think we're seeing enough of it to really have any rules. I mean, I think similar to, male breast cancer, we're using data from females, and
Well,
so that becomes more complicated.
that was a question I was going to have. If they're taking testosterone replacement, is that protective against breast cancer? I don't know.
We don't know yet.
Okay.
Studies are being done.
Okay. There you go.
Good.
All right. Well, I thought that was going to be more controversial than I guess it was, but we've all seen it. It's probably a little more common than people are talking about it now because it's sort of more mainstream and whatnot. So we're getting close to the end, but I guess any last thoughts about your practices, things, Katie, that you want people to know about the new therapies for breast cancer? I know immunotherapy. I know a little bit about this stuff, but it seems like a whole new world now.
Yeah, well, I think that luckily things are changing. Last year, I would say there were about 20 new updates in breast cancer. So I would say that the good news is that we're shifting the needle, and women are living longer.
Right.
And women who would not be considered curable 5 years ago are being cured now. So
Yeah,
I would say is that I
that's
think it's
remarkable.
important.
Bethany, any thoughts closing out about your practice?
I think menopause is an opportunity to really look at how healthy you want to be for the rest of your life.
Don't give up.
Don't give up.
Fight the good
Exercise,
fight, yeah.
eat well, sleep well.
Bourbon's okay, though, you said.
Take
Right?
care of your mental health.
Occasionally.
So I think nobody comes into my office saying, I want to spend some years in a nursing home.
Yeah. So take care of yourself. Women's health is really important to start worrying about in your 20s, probably, right?
Yeah, I think we teach women generational self-neglect. And so I think it's important just to reflect that in order to take care of everybody else, you have to take care of yourself.
I'm so grateful to Bethany Kolb and Katie Sanchez, our two female lady physicians that are taking care of all the women in Albuquerque. Thank you so much. Sign off. We'll see you next 2 weeks on The Doctor Is In.